So, hello, good evening, students. So, very soon you are going to have your exams, and these exams are going to be the final exams. And as it is said, the finals is the finals. Whatever you do in your league matches, it doesn't matter. What you do in the very finals, that makes the difference. The difference between a winner and a loser may be a fraction of second in a race, but the rewards are completely different. So, dear students, as your exams are starting from January 12th, so you are just around 20 days away from your exams. So, the EDEN 2 has come up with the revision series where all the 4 subjects which you have in final year part 2, it will be discussed, the important questions and the revision strategies, do's and don'ts, and through the app you will be getting various other informations also. So you have your number here displayed on the screen. So for all the past year questions, important questions, you can go through the apps. Okay, so dear students, as oral and maxillofacial surgery will be your 4th subject, and there will be a gap between the subjects to study. But what happens is it is the final subject, the last subject. So you would have started your BDS with anatomy, and you will finish with oral and maxillofacial surgery. So you have to hold your nerves, you have to keep studying, and definitely when the first exam starts, before few days you will leave oral surgery studying. So there will be a lot of gap, and then finally you have to take up the exam. So today I will be discussing some of the most important main questions, short essays and short answers. So it is not possible in a 1 or 1.5 hour time to finish each and everything in oral and maxillofacial surgery, but I will try my best to give you the maximum. Okay, so without this further time, let's go into oral and maxillofacial surgery, and in between I will be talking about the revision strategies, what you should be doing. So learn this, whatever I'm going to tell, and I have included the things which is most confusing, boring, which students don't study, make an attempt, but they are highly important. So those things I have included. Okay. So if you are to become a good surgeon must have an eagle's eye, a lion's heart, and a lady's hand. That is extremely important to be a good surgeon. So myself, Dr. M.S. Balakrishna, Dean Academics, Professor and Head in Department of Oral and Maxillofacial Surgery. So today I will be discussing the top questions. So dear students, what got you here may not get you there. With whatever hard work you have reached to final year BDS, final year part 2 BDS, with whatever hard work you have done before in first year, second year, third year, with the same kind of hard work you do now, you may not reach the next stage of life. To reach there, you have to do something more, something extraordinary. You have to reinvent yourself, and you have to make sure the next 20 days you are into the race. No deviations. You have to be completely systematic. So which over a period of time today I'll be talking. So please understand there is no elevators to the top. You will have to walk yourself. If you think there will be a lift, then you may miss the bus. Right. So the first question of the day, gate control theory. So this is a question which most of the students don't understand and they don't study also. So this is a question which I would like to discuss the first so that you get into the concept of it. So gate control theory, this is from your local anesthesia, okay? And this can come as a main question, a part of the main question. So you should know what is this gate control theory. Now, you would have seen in cricket matches, football matches, there are players who gets injured, who falls down, and suddenly their physiotherapist will come and he will rub that area. And once the rubbing and the massage is done, and after within few seconds, the player is playing again. A big ball would have hit, but he is has started playing. How is that possible? What kind of science is that? He's also a human being like you and me. If we bang against a ball, we get swelling, we get pain, we sit and cry. But here is a person who starts playing immediately. So that is all because of gate control theory. So let's discuss that. So whenever you get hit next time, you have an injury, you have pain, activate the gate control mechanism, which I'm going to talk right now. It's a 5 marks question. So keep your notes ready, keep writing it. This class is streamed in YouTube also, so you can go back and see again and again. So let's start. So before I start the gate control theory, this is the story. So please capture this image and frame it in your brain. So what is this image telling about? So here you see that there is a station which is called a brain, and then there is two trains coming up. One is a happy train. This one, it's a black and white photo. One is a happy train and another one is a pain train. So both of them come here and there is a person in the gate. So this is the person who will control the trains. Only one train can reach at a time. Both the trains cannot go. So it is the role of the gate man who controls the train. He will say, okay, either the pain train or the happy train reach the brain. So similarly, see, you cannot be happy and sad at the same time. Maybe morning you are happy, evening you may become sad. Or after you may be crying, after 5 minutes you may become happy. But same second, same minute, you cannot be happy and sad because only one train will reach the brain. So please remember this photo. Within next 5 minutes, we are going to come back again. Once I explain everything, I will say, okay, see, we have come to the same situation again. Right. So this gate control theory was proposed by two people. So first one is called Melzack and the second one is Wall. So what is this all gate theory about? This is all about a psychological mechanism. It's all in the psychology. See, you suppose you lose some 1,000 rupees. You kept it somewhere in your purse, wallet, and you lost it. You will feel bad for it. You lost your mobile. You will feel bad for it. So the psychology will make you remember it again and again and again. So that is a psychological mechanism. Love breakups. People go into depressions because they will remember their past. So it's all psychology. But at the same time, you lost 1,000 rupees in the morning. Evening, you get 1 lakh rupees somewhere. You will be very happy. You lost a mobile, but someone gifted you iPhone. You'll be very happy. You broke up with a girlfriend or boyfriend. You got some better version, better people in your life to move on. So it's all situational, that moment, and it is all psychology or psychological mechanism. So this gate control theory is based on psychological mechanism in which psychological factors will affect the experience of pain. So it is the psychology of the patient which will tell whether you will have pain or not. So two people, Melzack and Wall, started this. He proposed this theory, and it's a psychological mechanism. So this gate, as we have seen in the photograph, gate can open and close. Now, where are these gates located? So first and foremost, you should know where are the gates in the body. The photograph, you saw a gate man. It's evident in the photograph, but in our body, where? So these gates are located in the spinal cord. We have a spinal cord, brain in the spinal cord. It's located in the spinal cord. Now, this, what you see, this gate can control. I told you that gate man will be there and he will be controlling. So he can do either of the four things. For example, suppose there is a peon or a peon to the principal in your college. Some information has come to the peon. Some students are studying in the library and making nuisance. So that peon can go and tell as it is to the principal, sir, there is a complaint. There are some students who are talking and making nuisance in the library. Direct information went to the principal. Second situation, the peon can add up more information. Sir, they are not only disturbing the class, but they are playing also inside. They are running, screaming, shouting. This is all added thing. So the peon or the gate can aggravate or it can modify the information going to the principal. Third option, first is directly as it is telling. Second, adding up things. Third, it can decrease the intensity. Maybe they are making a lot of nuisance, but the peon may go and tell, the PA to the principal may go and tell, sir, they are talking, but it's okay, sir. They are at very low intensity. They are talking. Some people had problem, but that is sorted out. So that is decreasing the intensity of the information. And the fourth option, it can stop it also. The PA to principal will not tell this to the principal at all. So this is the four options. Directly pass. So information from a stimulus or injury can directly go to the brain, pass directly. Second, it can add up. Third, it can decrease the intensity. Or fourth, it can stop reaching the brain. So four things can be done. So these are the things. Gates are located in the spinal cord, and they allow the information to pass directly to the brain. Altered prior. Alteration can be up and down, increase, decrease. Or fourth option is the prevention. So remember this before we go into the next slide. SAME, SAME. Sensory are called efferent and motor are called efferent. So whenever I am telling or quoting sensory nerve, that means it is efferent nerves. And whenever I am telling motor nerve, it is efferent nerve. So whenever there is an information or a stimulus, you get an injury. Suppose a candle is burning and your hand got burned. So in your hand, there will be nociceptors. This nociceptors will carry the information via sensory nerve, that is efferent nerves, to the spinal cord. And from the spinal cord, your gate control theory, the gate man will be there. From the dorsal horn, the information will go into the substantia gelatinosa, very important term. And from there, it reaches the brain. So this is the pain pathway I'm talking about, which you would have studied in physiology in first year BDS. Pain pathway. So please learn that also. So this is the neural pathway. Now, this is the gate control theory. So please pay a lot of attention. Whenever there is an injury, okay, suppose my hand is there and one hammer hit it. Whenever there is an injury, first is the presence of injury is told by small peripheral nerves. Small nerves will go and tell there is an injury in your hand, there is an injury in your leg. Take out your hand. So who will tell the presence of injury? Small peripheral nerves. Small nerves will do small action. They will only tell. Then what happens? Cells in the spinal cord or nucleus of the fifth cranial nerve gets excited by this injury signals. So the gate, all the information, suppose your leg went and banged towards a wall, your feet. So the presence of injury, small peripheral nerves will tell. And all the small peripheral nerves will bring information to your spinal cord. And from there, all will get accumulated. And the small will become one huge. And then via large peripheral nerves, it will carry the information to the brain. So small information will become big, and through the large peripheral nerves, it will go towards the brain. So this is what you should know. Small peripheral nerves, only presence of injury. Large peripheral nerves, the accumulation of small peripheral nerves becomes big and it carries information towards the brain. Now, so once it reaches the brain, the descending control system originating from the brain modulate the excitability of the cells, transmit information about the injury. So information went up to the brain. There is an injury in your leg. From the brain, information has to come back to the body. What the body should do. So that is the descending. One is ascending, which is going towards the brain is ascending. So they interpreted that there is an injury. Then the descending control system will tell what is important and what is not important, whether what needs to be done. So they modulate the excitability of the cells. So the cells are, if it is increasing the excitability, more pain. If it decreases the excitability, then the pain stimulus, the pain intensity is less. So that is what Who will control? The descending control system, which is coming from the brain. It's just like your fan regulator. You want more speed, increase. You want less speed, you decrease. So that is the role of the descending control system. So now, as I told you, small peripheral nerves will tell the presence of injury. So which are those small peripheral nerves? A delta fibers and C fibers. So remember this name, A delta fibers and C fibers, only the presence of injury. And the large peripheral fibers, which will carry information towards the brain, is A beta fibers. So don't get confused, okay? A beta fibers, large peripheral nerves, and A delta and C only presence of injury. So this terminology, this slide, you should take a screenshot and learn this. Without this, you cannot do that. Now, let me give you an illustration, an example. So this is your finger and there is a hammer. So your hand got hit with the hammer. So what you do, once your hand gets hit, you rub your hand, right? So wherever you get hit, you rub it. So when you got the hit, the presence of injury. The presence of injury is A delta and C fibers. There is an injury. Then immediately you start rubbing the finger. So that is, once you start rubbing the finger, A beta fibers get stimulated. I hope I am very clear about this. So please pay a lot of concentration. Again, I am repeating it. When you get hit, the presence of injury is A delta and C fibers. And once you start rubbing it, the A beta fibers, large peripheral fibers, gets activated. So this is very, very, very important. So what happens now? So there is a hammer hit in your finger. A delta and C fibers got activated. This is the blue line, okay? A delta and C fiber, the presence of injury, it is going into your spinal cord. And simultaneously, you start rubbing that hand. So you start rubbing the hand, deep touch, that is, Pacinian corpuscle gets activated. They also go towards the brain. So both A delta and C fibers strain and your A beta fibers strain both reach at the same place. So this is what I was telling you right now. The beginning of the slide, both the trains come at the same point. So this is what they have reached at the same point. One is telling the injury and another one is massaging. And the A beta fibers is massaging. Now, what happened? The whole story game is played in this box, what you are seeing here. So this is extremely important. Okay. So now see this, what happens. Your A delta and C fibers, down you see A delta and C fibers, they come here towards the substantia gelatinosa. At the same time, A beta fibers, the peripheral nerves comes. Now, for example, you are playing a musical chair. Now, I want to sit on a chair. You also want to sit on a chair. You are pain and I am the massage, which I am massaging like this. I am the A beta fibers. So once you are trying to sit on the chair, I will go and push you and I will go and sit. So if you are pain, A beta and C fibers are trying to enter into the substantia gelatinosa and initiate the pain pathway. Immediately, this A beta fibers will come and it will say, you go, I will reach the brain first. So what happens? Instead of the pain stimulus reaching the brain first, that is your A beta and C fibers, it is pushed back and A beta fibers goes up. So that means the massage which you are massaging, that impulses go first. So what happens to the brain? The intensity of the pain is not reached, but the massaging is reached first to the brain. The brain will think, okay, there is massage going on, no pain. So it is a psychological mechanism. You fool the brain. There was injury, but the injury signals you said you go next, first the massage will go. So then the brain thinks there is no pain, only massage is happening. So you don't feel the pain. So that is what the whole story is here. So I repeat, your A delta and C fibers are going to reach substantia gelatinosa. At the same time, A beta fibers come, they will push it and they will go up. So all story is here. That is what I'm telling. So this is how this diagram, this thing I have taken from a book called Monims. It may be there in your library. So this is extremely important diagram. So this is nothing, same thing what I told right now. This motor system, this is going to the brain. So whenever there is an injury, what happens? The A beta and A delta and C fibers gets activated. At the same time, when you start massaging, the A beta fibers get activated. So the A beta fibers goes like this and it goes out. It reaches first. It is like a bypass road. You are not entering into the city. It will take the shortcut and it will reach the brain first. And it will tell that only massage is happening, nothing is there. So that is why if the normal pathway will be the small fibers will come and it will go to substantia gelatinosa, then the pain pathway, it will go to thalamus, and then only it will exhibit the pain pathway. That's the normal pathway. So before that happens, the bypass road A beta fibers will take and it will tell the brain nothing is happening. But there is an injury actually. So the brain gets, it's psychologically, it's all motivated. So I hope you understood it, okay? So the factors involving the opening and closing of the gate. So the amount of activity of the pain fibers, how much is the activity, that much the gates will open. Hugely hit, it will open more fast. Then message that descends from the brain also, that will dictate whether the gate has to be open or closed. So conditions that open the gate. So extent of injury, a small slap, nothing happened, but hit with a very hard hand, extent of injury will open the gate and suddenly there will be a lot of pain. Then emotional conditions, always you are in tension, worry, and anxiety is there. For tomorrow exam is there, what I will do. Then you have loose motions, you have vomiting, and the exam also will be bad. Because the whole negative thing opened the gates, and you have headache, no sleep at night. So your gates are open. So all anxiety, everything is going towards the brain. And you lost something, you're focusing on the pain and boredom, if you're suffering from, so that all initiates the pain. The gates are open. So conditions that close the gate. Medication, you're having headache, you take a tablet, the gates are closed. Or counter stimulation. This is what the football players, the sports person, the physiotherapist will come and counter stimulate it. So what happens? That A beta fibers will reach the brain first. And emotional conditions, you're tired, you have no energy, you take rest. The brain, the gates will get closed. So the pain impulses will not reach the brain. So these are the conditions which open and close the gates. And mental condition, distraction. You are having tension, you just get distracted. Something is not the thing what you wanted has happened in your life. Just get distracted, get away from the condition for some time. Things will settle down and everything will be fine. So these are the conditions which open the gate and which close the gate. So that is all about your gate control theory, 5 marks. So dear students, exams without anxiety, definitely that is not there. So you're just moving towards your exam, final 20-25 days. So you will have anxiety. And before the start of the preparation, all the students or most of the students are in this state. It is those students who do not plan, who do not have a timetable, end up like this towards one day before the examinations. So that is why the next 20-25 days, you have to divide a good timetable for all the 4 subjects. And please understand, in Kerala University of Health Science or any university you may be studying, all the subjects are equally important. There is no fun getting excellent marks in oral surgery and failing in prostho. So you will have to get equal performance should be there in all the 4 subjects. So you have to divide at least 2 times you should do the revisions before going for the exam. All your model papers or your mastering BDS, apart from your textbooks and the notes what you have studied throughout the year, mastering BDS questions also, please learn and go. Because 70 to 80% of the questions will be from the last 10 years paper. So if you do that, 80% you can easily do that. So divide the day into 4 parts and read equally, 2.5, 3 hours per subject. If you do it for a period of time, all the 4 subjects will go together. Next question, the recent advances in local anesthesia. Extremely important. This was a main question. Previously, gate control theory is a short essay, also has a main question. So recent advances in local anesthesia, extremely important. Please make a note of this, whatever I'm going to speak now. So now the first recent advances is acupal. So gate control theory you understood, right? A counter stimulation will be there and your A beta fibers gets activated and it reaches the brain first and there is no pain. Whether the pain stimulus will reach late. That is why before that only information went, nothing is there. So no, same concept, this instruments, what we are going to discuss now, they will be incorporating. So acupal is a cordless handheld compact device, what you are seeing here. So whenever you're going to give injection, before that you put it there and press the button, vibrations will be there. So what will happen because of the vibrations, the A beta fibers gets activated, counter stimulation. And then when you inject, there is no pain. So it inhibits pain by preconditioning the injection site with pressure and vibration. And the vibration will be simple vibration. The patient will have no problem with that. And the whole area is stimulated. So once you give injection, there is no pain. Patient will be telling, sir, you are such a great dentist, there is no pain. So this is the recent advances what you can do that. The same needle you are giving with injection, but no pain. So this acupal, this instrument, it integrates the pain gate control theory and the gate control theory. I have just explained that. Next one is dental vibe. So this is the photograph of the dental vibe. This is also on a similar terms and condition. It works. Only the company name is changed. Dental vibe. It's a cordless handheld rechargeable device. So this instrument also produces micro oscillations. Once you switch on, there will be oscillations and that area, there will be a small massage type will be happening. So that will be soothing, pulsating and percussive at the injection site. That the whole area will be stimulated. And then once you give injection, there is no pain in that area. Right, so patient friendly it is. So this is second one, dental vibe. Third one is safety dental syringes. So the photograph you are seeing it here. So here, the safety dental syringes have a protective sheet also. Generally, normal disposable syringes, you will take out the sheet. Here, there is a protective sheet which will help to prevent needle stick injuries. So, this safety dental syringes, again, types are there, Ultra, Safety Plus, XL, Ultra Safe Syringe. So, names and all, no need to go into detail that much. The fourth advance is, this is a 3 marks question, always it comes in the exam, euthetic mixture of local anesthesia. So this is like a cream which you apply on this area and leave it for 5 minutes and then you give injection, there is no pain over there. So this cream is a euthetic mixture of local anesthetics, which is called as EMLA, contains lignocaine and prilocaine in the ratio of 1:1. 1:1. So 1% is lignocaine, equal percentage is prilocaine. So this is applied prior to the injection, where you are going to give injection. Prior to that, you will apply, and then, like locally, it will be applied. And then what will happen? At least 1 hour prior to the procedure, if you apply, the best results are there, and very useful in children also. So it is just like a cream you are applying, and then once you give the normal injection, there is no pain. So while applying cream, there is nothing. The patient will feel very happy over that. Next is computer controlled local anesthetic device. It is also called as CCLAD. CCLAD, computer controlled local anesthetic device. So you see this instrument. This is one instrument with all buttons are here, right? So the local anesthetic solution will be inside this, and there is one cannula coming up, and your insulin syringe type needle will be there. Very small insulin needle type. And then this instrument is controlled with a foot pedal also. So whenever you are going to inject, so there are buttons over here. You want to give inferior alveolar nerve, so you just press inferior alveolar nerve. So that much solution only will come at that much weight. And once the solution is injected, a beep sound will come. And then you have got infiltration, you can do field block, you can do nerve block. So it is completely painless procedure. Patient will never feel the prick. Patient will never feel the pain. So this is the latest technology what in high-end clinics is being used. It's computer controlled local anesthetic devices. So all buttons, it's automatically, you just switch on and just go there and put the needle there, automatically it will work and just inject it, that's it. Highly efficient than traditional syringes, and you can control the speed. You're putting a pedal. So once you are in the site, you put the pedal down and then the solution will go. So the speed of the injection can be controlled by the pedal. But when you're giving with hand, you press it, everything goes in one shot. So some operator can give very fast, some can give very slow. But here, once the pedal is on, at the equal frequency, it will be going. Next one is compu flow. So this names and all things, learn this, okay? So this is an instrument. So whenever you're giving the injection, the fluid is going inside, the local anesthetic solution is going inside. So from the needle tip, how much fluid is going, the dynamic pressure is sensed here. So it permits immediate real-time measurement of fluid exit pressure at the needle tip. How much pressure and how much solution is going, the pressure generally it will measure. So this method of measuring the fluid exit pressure is referred to as dynamic pressure sensing technology. So please learn this also. Next is Stabident. So 7th or 8th local anesthetic device numbers I didn't mark it, but please mark it, okay? So it is used for intraosseous anesthesia when there is highly bone pain is there, right? When you are doing an alveoloplasty or you're doing an apexectomy, so the bone gets involved and you're working over the bone and a lot of pain is there. So this you can use, device used for intraosseous anesthesia. But this anesthesia cannot be administered to locations that are inaccessible. If they're so inside, it cannot be given. Only the superficial bones can be anesthetized with this. Next one is vibraject. This is again gate control theory, that vibrations will be there. So you can see this instrument over here, a normal syringe with the attachment over here. So this attachment will vibrate that area, activate the A beta fibers, and then the gate control theory gets activated. There is no pain. So it is a vibrating dental local anesthetic attachment that uses the gate control principle as its foundation. Again, same thing. So again, a battery will be there and the barrel will be there. Intense vibrations will take place first, and then because of the vibrations, the gate control theory gets activated, and then you can inject. So this is a beautiful technique where patient will have no pain. So that was all about your recent advances in gate control theory. So far we have done the gate control theory, a main question, and the the latest advances in local anesthesia. Next is the emergency drugs in dental practice. It can be a short essay. So you should know in and out of the conditions, the drugs, medicines. Very quickly with the flowchart manner, I will be going. So please learn this properly. So emergency drugs in dental practice, these are the emergency drugs starting from your atropine, diclofenac sodium, dexamethasone, glucose powder. The whole list is there. This should be there in every clinic. And then the continuation of that is emergency drugs, derifylline, dextrose, ranitidine, diazepam. The list goes on. The conditions are syncope, angina pectoris, myocardial infarctions, hyperventilation, diabetic coma, and then your excessive bleeding. So emergency condition can be in any form, or adrenal crisis, thyroid crisis, cardiac arrest, foreign body aspiration, epileptic attack, asthmatic, or anaphylactic reaction, anything. So these are the drugs, these are the conditions. So now let's see how to go for it. So whenever there is a syncope, make the patient lie flat. Always the head should be at the lower level, the chest should be up. So heart should be at a higher level. So the blood flow towards the brain is maintained. And if possible, hold the legs and elevate the legs also. And patient went into syncope. So or feeling dizziness, either way it can be. If the patient is conscious, he stands up but he falls down. Patient is conscious. So what you do is give spirit of ammonia. Spirit of ammonia, it's a respiratory stimulant. It will come in bottles. You have to put some cotton there, take a little bit spirit, and tell the patient to smell. So it will just give a kick to the patient. So spirit of ammonia, respiratory stimulant. These are all viva questions also. Then because the patient is conscious, give them glucose. Right, so this should be there in your clinics, glucose. This is the condition where patient was conscious. But if the patient is in comatose position, he is collapsed. So that time you can't give glucose. So that time give dextrose IV injection 25%. Extremely important. Dextrose IV injection 25% IV. So you should know how to give IV injections. Okay, very, very important. This would have learned in third year. So now dextrose IV injection, you should remember again, this we will study in diabetic coma also. So this is the management of syncope. Now next condition, angina pectoris. Patient has developed chest pain. It's not a heart attack, it's chest pain. So while during the procedure, if the patient is having chest pain, stop the procedure and give sublingual nitrate, sublingual below the tongue, lingual nitrate tablet, and keep it there for 5 minutes. You see little relief but not much. Repeat one more time. Not much relief. One more time. Maximum 3 times you should do it. Not more than that, and immediately call for medical help. You kept sublingual nitrate tablet. The pain is relieved. Then don't go for further treatment. So then that is an angina pectoris. You can consult a physician, and when everything is fine, then only continue. But because of your presence of mind and your acting at the correct moment, because of your actions, the pain got relieved and you could solve the problem. Now you are giving sublingual nitrate tablet and the pain is not relieved. Angina pectoris, chest pain, but the pain is not relieved. Then it could be myocardial infarction, aortic aneurysm, or gastric pain, either of the three. So what needs to be done now? Let us see one by one. So myocardial infarction. So chest pain is there. You gave sublingual nitrate tablet. It did not get relieved. So what will happen? Because it is a MI, patient will have pain across the chest. He will have a lot of sweating, and the pain will be radiating to the left arm. And the pain is not relieved by sublingual nitrate tablet. Then it's a situation where you have to act very fast. Don't move the patient, call the doctor, physician, give oxygen, and give morphine 5 mg slow IV. Start morphine. Ship to the hospital as soon as possible. Extremely important. So this is the management of myocardial infarction. Now, there is a chest pain. Pain is not relieved. It could be because of epigastric pain also, gastritis, gas problem. Because of gas problem also, chest pain can come. So this epigastric pain, this is the area. You can see here, this is the area, epigastric region. Somewhere here, lot of burning sensation and pain will be there. So for this, you have to give ranitidine injections. Rantac, what you have, Pantop 40, you call it, right? So this is your ranitidine injection IV. If you give, the pain will get relieved. Angina pectoris will get relieved. Next condition, hyperventilation. So hyperventilation, the patient is not able to breathe, right? He is feeling suffocation. So at this time, give carbon dioxide, not oxygen. So you have to identify hyperventilation properly. So what you can do is, to give carbon dioxide, you can make a funnel with a paper and put it on the patient's nose. So whatever the patient is exhaling carbon dioxide, again the patient will inhale the same carbon dioxide. So this is what you should be doing this. Next condition, diabetic coma. The patient is having diabetes and he collapsed. Now you don't know whether it is hyperglycemic or hypo. Patient has not told and he is just lying there on the floor. What will you do? Don't panic. Whether it is hyperglycemic or hypoglycemic, whatever it is, give IV dextrose 25% injection. This is the same injection what you have given for syncope. IV dextrose 25%. So now, once you give IV dextrose, and what is this dextrose? Carbohydrate. So once you give this dextrose, IV injection you have given, patient recovers, very good, or the patient will not recover. If the patient recovers, then that is hypoglycemic coma because you gave sugar, you gave dextrose. So there was deficiency, you gave dextrose, you gave sugar, it became, you gave carbohydrate, it became all fine. So that was hypoglycemic coma. So if required, you can give glucagon injection. So a patient being unconscious, you don't know hyper or hypo, with your this flow chart and presence of mind, you can identify and rectify it very fast, right? It all starts with IV dextrose 25%. Now, even after giving dextrose, your carbohydrate, patient does not recover. That means it is hyperglycemic coma. Your carbohydrate has not worked. So it is not hypo, it is hyper. So you give insulin injections here. So the insulin injection will help you to recover the patient. So I hope you understood in which condition you should give glucagon and in which condition you should give insulin injections. Next condition, you're bleeding. So whenever there is an excessive bleeding, be aware of this bleeding. It's a medical problem, huge problem. So give local hemostatic agents, styptics, what you call it, right? First thing is, if it's a bone, identify the source of the bleeding. If it's a bone bleeding or an arterial bleeding, try to find out. You will have your ball vermishers, like in prosto and all you use, right? Keep that ball vermisher and just go inside and go and rub and touch that area from where the source of bleeding is coming. It is just like welding or if you fuse that area. It's just acting like cautery. Okay, so that is one method. Second is you can give ethamsulate injections. Then Surgicel, foam will come, a gel foam. You can cut into small pieces, stuff it inside the socket, and then suture tightly. So the gel foam is there inside the socket, and it will be rich with vitamin K, and clotting factors will be there, and it will compress also. So that is called Abgel. It's a different companies are there. So these are the local hemostatic agents you can give. Next condition, adrenal crisis. The patient is living in stress. He cannot live his life without the tablets. And the tablet is nothing but your steroid tablets. So these are the patients who are on steroid. And the patient will be taking, for example, 100 units of or 200 units, whatever their situation, they will be taking one tablet per day or half tablet morning, half. As per the medical conditions, they will be taking in the evening also. So what you have to do is, whatever the dose patient is taking per day, same dose, 1 hour before the procedure, double the dose. Not 1 day before, not 1 day after, or not 1 hour also. It is just before the procedure, double the dose and give it. That means, suppose the patient is taking 100 units per day, that is for his normal survival. Because he is taking 100, one more 100, we give it before the procedure. So the first 100, that is for its normal survival, and the second 100, what you have given for the stress, what you will be creating because of the dental extraction or the procedures. So just before the procedure, double the dose. Same dose, what you are giving, give one more thing. Next condition, thyroid crisis. So here there will be lot of palpitations, right? Tremors will be there. So you need to handle this very well. So in these conditions, don't give adrenaline in local anesthesia. You have to give plain LAs, and along with that, chlorpromazine, carbimazole, and dexamethasone. It's all things you can give. Preoperatively also you can give if it's a known case of thyroid crisis. Next condition, cardiac arrest. So this you know that it's a short answer. So if there is no pulse, no respiration, no heartbeat, then start the CPR. Look, listen, feel, chin lift, jaw thrust. These are all stepwise you have to write. Chin lift, jaw thrust, and intermammillary lines, the nipples, you know that, connecting line on the left side at that level where the heart is there between the ribs, you have to compress. I'm not going into details of CPR right now. Please learn CPR separately. So this is the management. So you have to give adrenaline injections. 1:1000 concentration. Okay. And 0.5 ml subcutaneous also we can give. And if you are giving hydrocortisone injection, 100 mg IV has to be given. So these are the drugs in cardiac arrest which you should give: adrenaline and hydrocortisone. And the drugs what you need to again give is sodium bicarbonate 2 ml IV. ECG has to be monitored. Your PQR, all the intervals should be checked. Oxygen therapy has to be given for these patients. So please go back and learn these conditions again. The classes will be there with you. So this notes will help you a lot, this flow charts. Next is the foreign body aspiration. Something has gone inside and it's not coming out. So no drugs is there to take out a foreign body, only action. A maneuvers you have to do. And that maneuver is called Helmicks maneuver. So what is that? Bend the patient, go to the back of the patient, and with your fist here, give 5 blows. And once you give the 5 blows, hold in the epigastric region and give 5 abdominal thrusts. So whatever foreign body was there, repeat 2-3 times, it will come out. So this maneuver is called Helmicks maneuver. This can be your 3 marks question. Next condition, epilepsy. So an attack of epilepsy has come. First and foremost, stop the dental procedure. Whatever is there inside the mouth, take it out. If possible, put a bite block. If it's possible. If that is not there, any handkerchief or cloth or cotton or anything, keep it between the teeth. It will act like a bite guard. And suction, if you are there in dental chair, put the suction also. Because a lot of froth will come, so that can be taken out. Otherwise, aspiration will take place. And then the drugs to be given is diazepam, 2 to 5 mg IV can be given. It will calm the patient. Next condition, asthma. So generally, any patient, if they are not well, we say them go and lie down. But please never do to an asthma patient. Never tell the asthmatic patient to lie down. First of all, they are not able to breathe, and over that you make them lie down means they will permanently lie down. So patient must be in sitting position. And inhalers, salbutamol inhalers should be given. Deriphylline injections IV, hydrocortisone injections IV, and salbutamol inhaler. You should give that. Okay. So this is the vial. So here one mark will be there. So from that mark only you have to cut the vial. Next conditions, allergy or anaphylaxis. So whenever an antigen antibody reaction is precipitated, so you can give hydrocortisone, chlorpheniramine maleate, and ephedrine injections can be given. Severe bradycardia, heartbeat is going down less than 40. Then atropine injections, intracardiac, directly between the first and second rib, you can go there and then just give intracardiac injections. Severe post-operative pain. You give a painkiller, it's not reducing and patient is jumping. Then instead of giving non-steroidal anti-inflammatory drugs, try opioid analgesics, and that is tramadol injections will beautifully help. Diclofenac sodium, which is your non-steroidal anti-inflammatory, it will also work. So that was all about your emergency drugs. The whole chapter, big chapter it is, in 10 to 15 minutes I have squeezed in, I have given you. So that much also, if you are able to reproduce in the exam, it will be too much. Right. So dear students, you have to study, right? So the studies, when you're studying for a longer period of time, the concentration of the brain comes down. The activity, the focus of the brain comes down. So the maximum time when your brain is highly active based on a study is from morning 4 a.m. to 9 a.m. when your brain is 100% active. Then the second best time to study is evening 7 to 10 p.m. So what you do is you should know your strengths and weakness. Just that I study in the morning, you try to copy me, you will get headache. And just that you study late night, I try to copy you, I will get headache. So on your best time, read the toughest subject. On your worst time, read the easiest subject. So in this way, what will happen? You will love the subjects and you will master the subjects well. Otherwise, when you are very active, the easiest subject you are reading, only that subject will be easy and good for you. All other subjects you will start hating it. So use this mind power technique. Next is ASA classification for patients. So this is for the general anesthesia. This also comes as a 3 marks question. So main question, short essay, short answers, a mixture of questions I am explaining. Right, I'll see how much I can go and maximum I'll try to cover. So this is the actual answer. ASA 1, 2, 3, 4, 5 and 6. So for this, I'll give you an example. With that, if you can read, it will be very easy. ASA1 is a normal healthy patient. ASA1, a normal healthy patient. So that can be associated with first year BDS student who has come very happily from the home. All the parents are asking every day, the entire college is behind them giving full attention, right? No ragging, food is served on time, relaxation in 3 hours. So they are the VIP people. And so they are normal healthy patients. ASA2 can be related like second BDS students. Once they have written biochemistry and gone into second BDS, they get pharmacology, preclinical works, everything gets rejected. So a patient with mild systemic disease or significant risk factor. So mild only, not much. So they face the difficulty. ASA3 is the third BDS student who goes into clinic, but they see that there are final year students and interns who are getting the maximum schooling, so they can roam freely. Third year, they are there in the department, but they are not monitored. So no threat to life. So ASA3 is a patient with severe systemic disease, which is not incapacitating, not a severe problem. They are under observation, but not threatening. Then comes your ASA4. ASA4 is the final BDS students. So it may be you all, a patient with severe systemic disease, which is constant threat to life. So your every action is monitored. Anything goes wrong, there will be constant threat to life. Exams, internals, vivas. Just on a funny mode, I am telling so that you will remember all those things. Then is ASA5 is the house subjects. They're always sitting, they don't get up, and every time on phone only. So a moribund patient who is not expected to survive without operation. And the ASA6 is your postgraduate students. These are the postgraduate students who have, those people have no feeling. Whatever is happening, they are taking insult, injury, stress, motivation. For them, the whole life is work, 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 work. Just on a funny note, I kept this. So ASA6, a declared brain dead patient whose organs are being removed for dural purpose. Please learn this 6 ASA classification for general anesthesia. Patient category, very, very important. Once you replay this, you will learn this in a very easy manner. Next question, HBO therapy. Extremely important. So this HBO therapy is given for the patients who are having osteomyelitis and osteoradionecrosis. Osteomyelitis and osteoradionecrosis. Now, HBO therapy is done in a chamber. It's a special chamber, what you are seeing here on your screen. So inside, it's like a shuttle where you go inside and the doors are closed. So there is a change in pressure, there is change in the temperature, there is change in oxygen level also. Everything is changing. So this osteomyelitis, generally it happens, or osteoradionecrosis, at the atmospheric pressure 1. So right now, whatever we are living in atmospheric pressure 1. And we inhale oxygen from our mixture of gases, that is around 19 to 20%. So this person's patients are kept in a chamber, and then instead of 19 to 20% oxygen, they are given 100% oxygen. So 5 times more oxygen. A tsunami of oxygen is there. Then normally the atmospheric pressure is 1. Inside the chamber, the atmospheric pressure is 2.4. 100% oxygen, 2.4 atmospheric pressure for 90 minutes in length. 90 minutes continuously, they will be wearing the mask. 5 days per week. So this is how the treatment goes. And this is called, the unit is DIVE, DIVE. You can see here DIVE. So what is one DIVE? 100% oxygen, 2.4 atmospheric pressure for 90 minutes, one DIVE. So this is what. So once the oxygen is going, such a high pressure oxygen, right? Normally 19-20%, here 100%. So in your tissues, there is a tsunami of oxygen. The cells who were dying, apoptosis was happening. Suddenly they get stimulus because so much kick they get. So the tissue tension rises to 150 to 250. Normally the tissue tension is 10 to 15 at hypoxic levels. But when this mask with that in the hyperbaric oxygen chamber they wear, 150. So it's almost like what a significant 100 times increase it is. So what happens? When the tsunami comes, the cells which were dying, they get stimulated. So there is fibroblast collagen production, vascular proliferation, and neocellularity. New blood vessels will come, new cells will come, new blood vessels will come, and fibroblast collagen production. So again, a new life come in them. So this is what the mechanism it is. It enhances healing by a direct bacteriostatic effect on microorganisms. Oxygen, when you take bacteriostatic, and suddenly there is jump in the life. So the basic three things happen is new angiogenesis, new blood vessels formation, fibroblastic proliferation, and collagen synthesis. Okay. So this is the diagrammatic representation. This is what happens. Now, this hyperbaric oxygen therapy, what we are giving, this is as per Mark's protocol. Marx is the name of a person, a scientist, who advocated this protocol for osteoradionecrosis. So if you're writing a main question comes for osteoradionecrosis, you will write 5 E's, 5 P's, clinical feature, everything. In the management part, you have to write this. So you have seen the chamber, the photograph I have shown you. You know what is one DIVE. So now what you have to know is, there are some stages, stage 1, stage 2, stage 3, and stage 3R. In any stage, the number of dives is fixed, that is 60 dives. That means your quota is 60. So that you please remember that. Now, the patient is diagnosed with osteoradionecrosis or osteomyelitis. Normal antibiotic therapy is not working. He needs HBO therapy. So what happens? Stage 1, the patient comes. Initially, when the patient comes, give 30 dives, like a welcome drink. 30 dives are given. And then send the patient back, recall, and then check the patient. If the patient shows improvement after the hyperbaric oxygen therapy, total 60 dives in one stage, 30 only you have given initially, and send the patient back. Once he comes back, improvement is there. Very good. Take your balance, 30 more, and make a total of 60. So once again, improvement was there, you give again 30, follow the patient, again improvement, then no need of further treatment, he will be fine. You gave initial 30 dives, patient gave no improvement. So that means something else has to be done. What you have to do? You have to do something more. Okay, that I will do in stage 2. But you take the remaining 30 of stage 1. Stage 1, 60 dives. No, 30 given, no improvement, and then again next 30 is given. So total 60 dives is there. So no improvement was there, come to stage 2. Stage 2, okay, again a welcome drink of 30 dives is given, and then sequestrectomy, removal of the dead bone, and primary closure is done. So remove the dead bone and the primary closure is done. So this is the extra activity what you are doing in stage 2, and then give the remaining 30 more dives. If the healing is not taking place even after sequestrectomy and primary closure, then the patient goes into stage 3. In the stage 3, give initial 30 dives and do the resection to bleeding. Cut that part of the bone. It's no use. Then hyperbaric oxygen therapy is continued to make it 60. So I hope you're understanding. In first stage, give 30, send the patient back home, come back, healing, very good. Take remaining 30, treatment permanently closed. Not healing, okay. Take the balance 30, come to stage 2. After the initial 30 dives, you do sequestrectomy and primary closure, and then give 30 more dives. Is everything fine? Good. Give 30 dives. Not fine, come to stage 3, where initial give 30 dives and then do resection. So once you have done resection, you have to do reconstruction also. So 10 weeks after the resection, the patient is given additional 20 dives. So initially everywhere we were giving 30 dives. Now break it into 20 plus 10. 30 can become 20 plus 10. You gave 20 dives, did the reconstructive surgery, give the remaining 10 dives. So 30 dives it became. And because you have done a reconstructive surgery, a metal implants or something would have been, rods would have been kept, titanium, so no need of further treatment. So it is a non-living thing which is there inside the body. This is the marks protocol which you should learn. So we have done huge things today. So I hope this will make a difference for you, right? So please go back to these videos, see again and again. And if you require more sessions like this, do let us know. We will definitely come with other questions. Okay. So now the next 20 days, divide the whole 4 subjects into 4 fragments, and I suggest you daily you should go on a sequential manner. Okay, not reading one subject for 5 days, keep it close, and again next subject for 3 days, close it. So by the time you reach the last one, the first subject you will forget, and tension will come. So better divide all the 4 subjects in a day equally and start reading like that. And the revision is the key. You should have a revision hour. Without revision hour, you will not be able to succeed. So in your day, for every subject, 1.5 hours, you should revise the previous things. And question banks, don't forget, you're mastering BDS question bank, and in Eden2 apps, there are question papers or everything. You don't have to search. Everything is in the Eden2 app. If you go there, you will get everything. Okay, so that's all for the day. Further questions if you want, based on your request and demand, we'll see that. If it is required, we'll come up with further questions. So, okay then, thank you so much.